The topic tonight is Dead is Dead. Our guest speaker is Joel Demers, and Joel is a paramedic, having served as an EMS education coordinator for the state of Department of Public Health of Connecticut. He has over 30 years of experience in community-based commercial and critical care EMS and education. While serving also as a regulator, Joel also continues to practice as paramedic and clinical preceptor in New York State. And it's happy to, we don't always get to see this and everything, but his newest EMT partner also happens to be his 17-year-old daughter. Joel's topic tonight is a pretty hot topic. In there, we get a lot of requests for it and everything. So I think without further ado, I'm going to turn this over to Joel and let him do his presentation tonight. Joel.
Thank you, Steve. What I noticed is that on the list of attendees, I've got lots of friends from Connecticut, and my daughter is not one of them. So we'll be sure to harass her about that later on. So I'll put my presentation up here on the screen and let me know when we're good to go.
Okay, Joel, you're good.
Yep, we are good. Thank you very much. Well, most of the time we talk about how to resuscitate, but there are times in our job where we need to make the other decision. So tonight we'll go over best practices when deciding when it's appropriate to terminate resuscitation or not initiate resuscitation. So I have no special conflicts of interest. As you heard before, I do work for the state of Connecticut, but I'm here tonight in my own capacity. So I'd like you to join me on a dispatch. You're on duty in a rural town. You're dispatched out to a report of a pedestrian struck, and it's on a small residential road. Your community is served by a volunteer BLS transport provider, and there's a full-time paramedic service available, and you have a selection of 3 different hospitals nearby. So your local community hospital is 25 minutes to the west. You've got a level 1 trauma center 35 minutes to the west, and a level 2 trauma center 20 minutes south of you. There is helicopter EMS in this area. However, they don't typically use it because of these relatively short transport times. So as we go forward with our call, you get on scene, and first responders find an adult male who's laying on the roadside. He has one of these backpack leaf blowers attached to his body, and he's also pushing a leaf blower. So he apparently was struck by a vehicle that took the corner and pinned him between the backpack and the wheeled leaf blower. So there's a little bit of damage to the car. The operator of the vehicle is fine. They're on scene. There's just this one patient, and the patient's not moving. But they can't reposition him because of the backpack blower. So they cut the straps off of the backpack blower and reposition the patient, and they scan his body and see that there's some blood coming from the left shoulder. His body is generally deformed, kind of like he got hit by a car. So he's in a bad place. One remarkable injury is that he has a large axillary injury that's torn down to the bone and tissue. However, there's not much hemorrhage going on. And as they continue to assess, they also discover that he's in cardiac arrest. So our BLS crew starts good quality CPR. They've got a good team with all their appropriate equipment. He gets ventilated. There's acceptable chest rise and compliance. They do use an AED, but there's no shock advised. And as the paramedic arrives on scene, they apply the leads and see that the patient has asystole with a little bit of agonal PEA here and there. Care goes on, IO access is gained, the usual ACLS is initiated, epinephrine fluids. This is not a blood transporting agency, so that's not available. Paramedic puts an eye gel in, gets acceptable capnography, continues with bag valve mask, capnography is at 20. And because of the nature of major chest injury, the paramedic performs bilateral chest decompression, and the decompression produces only a little bit of blood, no air rush, and no change in compliance of ventilation. So it's time for that paramedic to phone a friend and gets on the line to the local medical direction and presents the case and requests permission to terminate the resuscitation. The physician at the local emergency department takes the call and goes through the patient report and says that maybe we should just work the patient for another 20 minutes. So we've already got 20 minutes in, and we're going to do another 20 minutes. The paramedic decides that instead of sitting on scene and initiating further care, we're going to do that same care while transporting to a trauma center. And in this case, they decide to go to the level 2 that's about 20 minutes south of the scene. Ultimately, as expected, the patient was declared dead in the emergency department, and they invested about 45 minutes of resuscitation, 2 crews, and the entire ER. I want to compare this to another scenario where we have a motorcyclist down who's thrown, and this motorcycle ran full speed into a slower car in front of it. The rider was ejected. The patient's pulseless, they're apneic, they're asystolic, and the same paramedic decides that this time we're going to declare the patient dead and not provide resuscitation. So it brings up the question, what's the difference in these cases? Did we need to provide resuscitation efforts for the first one? Is the second one less valuable? Probably not, but we do have some standards that we can look at to see which is better. In the first case, we had a significant multi-system trauma, a patient who's pulseless, they're apneic, asystolic. We've invested 60 minutes of ALS care, activated a trauma team, tied up 2 EMS squads. In the second one, we had the exact same patient presentation, but within 20 minutes, our crew was back to watching Netflix at the station. We do have some standards to look at. The first thing we look at is the research about traumatic cardiac arrest. And I was able to select out 4 different studies and see that out of the hundreds of cases of traumatic arrest, only a small number, in fact, it comes down to less than 2% of people survive. This tiny fraction of people who survive did not have any follow-up on what their quality of life was. So if we find that these few people are saved, we have to wonder why we're working so hard with traumatic cardiac arrest. And for the visual learners in the group, the gray people here are not surviving, and the 2% do survive. So your chances of surviving are really slim once you've gone into traumatic cardiac arrest. Friend Dr. McSwain was part of the consensus paper that was made up by National Association of EMS Physicians and the American College of Surgeons. They got together and agreed on when it was appropriate to withhold resuscitation in traumatic cardiac arrest. Specifically, they said that when there's cardiac arrest secondary to blunt trauma, if the patient has no palpable pulse, no signs of breathing, and no organized EKG rhythm, we should just immediately withhold resuscitation. The chances of survival in cases of blunt trauma with asystole are nearly 0. So this is a pretty good standard for us to work with when it comes to blunt trauma, which would include our car accidents. The second category that group agreed on was for penetrating trauma, that again, if this person has no pulse, no breathing, no organized EKG, obviously no physical movement of the body, and just a confirmation that there's no pupillary response, that it would be appropriate to withhold resuscitation in this case also. So in 2 different sets, whether it be penetrating trauma or in blunt trauma, it would seem reasonable to withhold resuscitation efforts when the patient is asystolic. In all cases of trauma, however, when a patient has these obvious signs that there's no future for life, decapitation, transection of the body, rigor mortis that's in place, dependent lividity or decomposition, there's absolutely no reason to initiate resuscitation with those people. And we see that also with non-traumatic patients. There's some discussion also about prolonged CPR being a reason to consider termination, that there's more than 15 minutes of CPR required on scene or a 15-minute or greater transport to a tertiary facility, that we should consider terminating resuscitation. In these cases, the chances of survival are down below that 2% chance and probably not worth pursuing. There are a couple of exceptions to this that we want to make sure to keep in mind. Patients who have suffered from lightning strikes typically have a longer electrical phase of cardiac arrest and therefore should be worked. Those who had hypothermia had some neuro and cardioprotective efforts from the hypothermia, and the same thing with drowning. And as we learned about football before, if a patient suffers from commotio, we want to definitely give them a chance, even though that is an external trauma that happens. Being a direct injury to the heart, they get a better chance of survival. So in these 4 different categories, we want to keep in mind that there are exceptions to termination efforts. So what are some of the things that can make a difference? Primarily, if you are working someone who's in cardiac arrest and you believe that there are things that you can do, bleeding control with pressure bandages, wound packing, Tourniquets, hemostatics, and pelvic binding. These are good things to prevent a person from going into traumatic cardiac arrest. Decompression of the chest, and if your area does it, either finger thoracotomy or chest tubes are appropriate. Aggressive airway management is important. Some fluids, we want to be careful with how much fluid we're administering to a person. And if it's available, TXA and field blood transfusions. Here in our state of Connecticut, we now have several agencies who are carrying whole blood in the field, and we're seeing nationwide an increase in the amount of whole blood that's being transfused in the field, which is really good. So I'd like to touch on the local protocol because we're here in Connecticut, and I'll then spread this out to other states and see who has other protocols in their area. Here, our protocol does come from our State Department of Public Health. And our protocol here in Connecticut is that every level of provider, from EMR up to paramedic, can consider not resuscitating if there's obvious signs of death or injuries that are not compatible with life. Specifically, paramedics can consider termination of resuscitation if they have a prolonged transport time and there's no ROSC despite appropriate advanced care. And that could include things like airway management, needle decompression, pelvic binding, fluid therapy, and maybe blood. So those are appropriate times not to initiate or continue resuscitation. Because we have blood available now in Connecticut, we do require that a physician consult be used if blood was administered. And we can cut back on our scene time and really get moving towards an appropriate facility whenever possible. We have a requirement here in Connecticut that whenever a person is not to be resuscitated or presumed dead, they have to have all 5 signs of death. So these are clinical signs of death for us. An unresponsive person, they are apneic, they don't have any pulses, they have unresponsive pupils, and no heart sounds available. Once those things are confirmed, we can go ahead and withhold resuscitation. I don't know what else to do. Is the audio usable? Can somebody give me a little feedback on that? Steve?
I think it's okay.
Okay, thanks. I saw one message there.
Yeah, it's a little scratchy, but I think it's okay.
All right. Well, we'll have to pay for better internet soon. So in addition to those signs, we're also looking for any of the factors of death, and at least one of these has to be present. And this is for all EMS providers. If there's obvious signs of death, decapitation, deforming brain injuries, incineration, things like that, lividity and rigor mortis. And if both of those are present, we've got to win. So that's our Connecticut providers. We divide things just a little bit when it comes to the paramedic versus the non-paramedic. Paramedics can utilize an EKG to confirm that there's no organized rhythm. On the other hand, EMTs and advanced EMT providers can contact medical direction to confirm orders to presume death. So going from Connecticut protocol back up to the national model guidelines, realizing that NASEMSO, the National Association of State EMS Officials, puts out model guidelines, and those model guidelines are not law, but they are recommendations, and they specify that for adult patients who have blunt trauma, if the patient's apneic and pulseless, has no EKG, we're going to terminate resuscitation efforts. That matches the Connecticut plans. When it comes to penetrating trauma, we might also consider assessing pupillary reflex, spontaneous body movement, and organized EKG rhythms. And NASEMSO recommends using direct medical oversight or calling a physician for the termination on those cases. So these are model ideas. There's certainly the use of pre-hospital ultrasound. I saw somebody mention that in the chat to confirm an absence of heart motion when we have PEA. And this is also a good way to look for obvious internal bleeding. So as this becomes more available, we'll do really well to use that for cardiac arrest of the trauma setting. Now, a lot of traumatic arrest turns out to be a crime scene, so we need to consider how to protect that scenario. And we can do that by limiting the access for responders. If we're going in just to make the pronouncement, one provider can usually do that. If we are working a full resuscitation and then calling it in the field, we want to preserve any physical evidence that's there. EMS providers have a crucial role in protecting the scene when law enforcement is going to take over. Medical equipment should be left in place. If there's EKG leads, IVs, IO, airway devices, anything that's disposable or consumable, that should get left in place. Obviously, our equipment goes back with us. And it's important to note the body position. And if we have to move the body for resuscitative efforts, make sure that someone makes a mental note of how the body was found initially. The responding police will appreciate that information afterwards. If the family is present or other close ones when we have to withhold, terminate resuscitation, the EMS clinician might be called upon to make that notification and to share the information with them. We frequently see that death notifications are made by police, but here in EMS, we occasionally have to make that communication. When we finish resuscitation efforts and the patient's care has been terminated, we now have to turn to the secondary patient, which is the family members and their friends that are there. And it's good to use the patient's name when we're talking to them. Try not to refer to them as the patient or the deceased. And use very clear terminology. The D words are good, dead or died. And we try to avoid using any euphemisms like passing away or moving on, because it leaves people with too many opportunities for hope. We don't want confusion there. It is good to explain the efforts that you took. Tell the family members the things that we did do to try to save them. And keep it simple. We try to avoid any medical jargon, any fancy terminology that they may not understand. A couple of good thoughts too. It's important for us to not impose our feelings on them or to compare how we would feel to their feelings. And avoid any specific religious references or terms. We don't always know what those people feel and how they feel about death. A couple of take-home points for you today. Traumatic arrest can be worked in the field. There's no reason not to do it, but we can certainly consider termination. If a patient has an unlikely prognosis, it's appropriate to terminate resuscitation. Consider doing the big interventions, applying tourniquets, airway management, needle decompression, or thoracotomy, and administering blood in the field. These are the things that can prevent a person from going into traumatic cardiac arrest. So we have a short discussion tonight, not very much. If you're interested, my contact info is on here, and you're welcome to either take a shot of this or we'll get it to you later on. And if anybody wants references, if you go to my website, you can have a copy of the entire presentation. We've got a whole bunch of references out there. And what I'd like to do is I'll take a look over at the chat. I see some questions. I see Derek asks, pelvic splinting and what criteria do we consider for a pelvic binder? That question actually just came up today at work. I think for pelvic binding, we're looking at any time that there's significant trauma in the abdomen, pelvis, and upper legs area. Pelvic binding would be appropriate. I know a lot of flight medical services are now doing that routinely. When it's not indicated is isolated femur or hip fractures. So it would not be appropriate to do a full pelvic binder for that. Really, the goal of pelvic binding is to reduce internal bleeding as opposed to just splinting broken bones. So it's definitely a big thing now. David mentioned the use of ultrasound, and as we see that in pre-hospital, that will definitely be a big thing now. This is when it comes to termination in the field, we usually make that decision within the first couple of minutes. There's not a lot of diagnostic work to be done. And the question is the Pre-Hospital Blood Transfusion Initiative Coalition. And I think we're going to see more use of blood in all trauma cases, anytime that we see blood loss. And we're also going to see it for non-traumatic bleeding too. So we'll see it for GI, OB type emergencies. So I think we're definitely seeing more of that coming up soon.
I think the question about blood products and how that affects the discussion about termination or not resuscitating someone. I don't think in the discussion or the science for using blood in the field, we're talking about people that fit the criteria for not to resuscitate or to discontinue resuscitation. That in effect would be a waste of the blood, could be argued. Wouldn't you think or agree?
So I think that's really right. That if we already are considering terminating this person and not initiating resuscitation, I would not hang blood just as a matter of course. With our local blood programs now, they're saying that the worst thing they can do is waste a unit of blood after they opened it. It's just tragic to waste that good product. It brings up the mental health factor. And one of the things I like to do when I'm operating a scene is to first make sure that nobody has any other ideas on how to initiate resuscitation. Anyone, the newest member of the crew, the police officer, a bystander, if someone has an idea and wants to try something, by all means, it would be an opportunity for everyone to be involved. The mental health aspect of termination and resuscitation is really significant. And in EMS, the last few years, we have started to recognize that mental health is just as important as our physical health. And the people that work in this field deal with so many traumas that it's really hard to deal with. And let's see here, we've got some new information coming out on best practices for blood administration. This is definitely the hot topic. Every meeting we go to, this is the discussion.
See
We
the
do have
comments.
one, we do have one here from, he says in many rural areas, much pushback on field termination versus transport, even in transport is 30 minutes, plus. Any ideas how to make providers more confident in non-transport? Again, it's education, understanding the process and everything, and look at the data that's out there. There's a tremendous amount of data, as Joel discussed in there, and supportive paperwork and supportive papers from NASEMSO, NAMSP, American College of Surgeons in there that I think help provide a comfort zone in there that you would be making the correct decision if you check off those boxes in there. Look at the National EMS clinical guidelines and everything. They have a lot of resources available in there for research and data on the same topics. But again, it's educating your workers and your peers in there on the correct thing and supporting it with data versus opinion.
And Joel, I think in this discussion, the education that Steve's talking about, as far as to bring out what the black and white is about who we can save and who we can't save, in working against the nature of first responders at all levels, particularly when it's friends and neighbors taking friends and neighbors. I think it's going to be really important for part of that process to have strong participation by medical directors and also mental health professionals. When you're talking about people acting against their nature, it's a tough call to make, and it needs to be a broad perspective to help people get to that spot.
Yeah, I agree with that. I live here in a town of 6,000 people. We're volunteers in this community and we know everybody. So it is really hard to make that decision. And I know typically the end user, paramedic and EMT, probably isn't really focusing on data. But if we're able to show some of these studies and share with them that the percentage of saves is so minuscule that the trauma on the staff and tying up all the resources just isn't worth it there. I see someone ask the question about theatrical resuscitation. Yeah. And I'm not sure that I've ever been guilty of theatrical resuscitation, but there are times, especially in more urban settings, we found, I worked in a city with some gang violence. We would take people that otherwise we would pronounce on scene, and we'll take them to the hospital just for the safety of the scene. Because if EMS is not doing something, then they're getting harassed by other bystanders. So we'll do a transport in that case, and that protects everybody involved. As far as the legal paperwork that's involved, generally a DNR or a POLST or MOLST form does not apply to a trauma event because it's not the expected cause of death. So a person could have a power of attorney. They usually don't do much for us in the field. But if I found someone who had a DNR and I guess they were on their way to dialysis and had a massive car accident, I don't think I would make my own decision on that. I think it's a great opportunity for the call to medical control and have a chat. We have a person who passed away from a non-expected death reason, and that's usually what the DNR is for.
Interesting comment about organ transplant potentials. That's a very sticky area to be in, to do aggressive resuscitation on somebody that has, for a lot of reasons, for the family that is looking at somebody that they are fairly confident has passed, and it's an interesting conversation, and it's wrapped. There are protocols wrapped around it to help make those calls. Um, but I would think resuscitation just for the potential for organ donation is a very difficult discussion.
In some places, also, if the patient has been in an arrest situation, everything in the organs have been without blood flow for a while, some of those organs may not be viable for retrieval in there. But again, there's also other organs throughout the body that, regardless of the time, that can still be utilized.
See, Kelly brings up the disconnect between the ER and the field crews being afraid of getting in trouble. And, this has changed. I know over my career, it used to be that every person that we came in touch with got full efforts all the time and a full transport. And we were bringing in absolutely non-salvageable patients in cardiac arrest, both medical and traumatic, every day to the ER. And now we've really reduced that, which is in line with more of our developed countries. It doesn't make sense to bring somebody in when you're absolutely sure you're just going in to get pronounced dead.
Any thoughts on the resuscitation for transplant? I don't have any strong answers for him. Only to say that it's controversial in trauma protocols. I guess that's where we'll stay. It's a sticky wicket.
Yeah.
Well, it's interesting because it's not just the solid organs you think of, the corneas, the skin grafts, the things that usually aren't ruined. If you have that ability, and it would be great to have that pre-planned with your physicians, your medical facilities, and your procurement teams to actually have a plan of action for who they would like to recover, as opposed to us just guessing in the field in the heat of battle.
Yep. I think that goes back to Steve's point about education and training, and then collaboration with the different entities. Because if the transport teams have a policy and a desire, and you have families that are filling out the paperwork so that their organs are to be made available if the situation arises, we should tighten up those gaps with those protocols so that we understand if we don't know the answer in the field, we know who to ask.
I see my friends at UConn are asking again about DNRs and not using them in traumatic arrest. It certainly wouldn't be appropriate to say that they're not applicable, but I would give them a second thought because it's not the intended method of death. When a DNR is generally there because it's the end of a clinical process, and a person who suffers a sudden traumatic event along the way, I would at least think twice before not considering any resuscitation in that case. It might be also that someone who's suffering from a terminal condition decides that suicide is the best answer. And in those cases, we might have an honest case of when the DNR could apply. So I think it just requires a second thought because it's not the intended process.
It'd be a good time to involve your medical control at that time.
I sure like to finish off my patient care report on those questionable cases with explaining that I did consult with somebody who gets paid a lot more than me and has much better insurance than me. That's a nice way to handle that one.
If we talked, I'm sorry, go ahead, Steve.
I just, again, please feel free to use the chat section to make any comments or questions here while we got, while we have a little bit of time.
I'm glad to see that Nebraska is following suit with similar protocols. That really makes sense. Is there anything unique for Nebraska ALS providers? You can see that in the first case scenario that we were talking about, medical control was not as supportive of termination, and that was unfortunate. But it seems like over the years we've gotten a little bit friendlier with that process.
Yeah, well, and I think the national clinical EMS clinical guidelines and everything has helped answer a lot of those questions for some of the states and services and everything, and I think we see a lot of them do follow some of those guidelines or those guidelines in there when it comes to termination, resuscitation events and everything.
Just looking through the notes, see if we missed anything.
And that was a great list of protocols right there. Thank you very much for Nebraska.
Right. Yep. Yeah, I think that follows a lot of what we're seeing
Any
nationwide.
thoughts on kids, Joel? I know that's always the hardest thing, and I thought about that because somebody talked about the theatrical resuscitation. And I remember running out a lot of houses, cradling the kid like I'm working them, just because it's like this is not the place for everybody to address the terrible thing that's happened here. Let me get people off scene into the hospital where teams can work with this family. And again, it's been a while since I've been in that place, but it's difficult sometimes with kids, and it does become a much bigger scene, doesn't it?
It really does. And there's so much that's involved in the heart there and not just in the mind. And I would never condone theatrical resuscitation, but we might choose to err on the side of resuscitating if it was best for everyone else involved. And it might be better for you and me as the providers to mentally know that we didn't just follow the protocol, but we also gave the appropriate medicine. There's also the cases we know where a seasoned provider might estimate that a cardiac arrest is not viable, but we have students and they're practicing their skills. And when we're on the line and the decision is that they get to exercise appropriate care for a cardiac arrest, that might be an option. So there are different degrees of dedication to the full resuscitation effort.
If I could, to Will's point, I mean, peds are different, and you carry them out, sort of pseudo-coding. My philosophy always was on the street is that I don't get enough. My pay grade is too low to pronounce these kids dead in the field. That there's someone who gets paid higher than I do to break that to the parents.
It's a tough scene. It's always
To
been.
be able to explain that you did everything within your powers. I think that will help you sleep better at night and help the parents in the grieving process too.
I will say too, Joel, one of the most frequent requests we get for people is more on peds. And my feeling is after we've done a few of the pediatric presentations, the request for more on peds still comes. And I totally get it. They're looking for stuff that we don't have. You know, that nothing's going to make you more comfortable with a sick kid, except knowing that, as you pointed out, that you're doing everything you can and you're doing everything appropriately and giving that kid their best chance. But when you're a provider with a kid that's doing poorly, it never seems to be enough. You're always looking for something else, that you can do.
I think we can probably reach out to our partners at EMSC, EMS for Children, and get some more trauma-focused information. Here in Connecticut, we have 2 pediatric trauma centers, and they certainly do specialize well and provide us with lots of feedback. And I know every state has that option, and we should make sure we take advantage of them whenever we can.
That's a good thought, and it may be towards where part of our discussion has been. It's not just about the medical care, but it's about where our heads are at with these situations, and it might be good to have a discussion about how we deal with that. Particularly again, Joel, like we're talking about friends and neighbors, taking care of friends and neighbors. How hard is that when it's? I have dear friends, and actually Steve knows one of these guys, my deputy chief. He was a diver, so he had to go recover his nephew. I mean, we know stuff that we have to do, and that's a good point. Maybe we need to address that a little bit more, a little care for the providers.
Well, I think that's an area that is not utilized enough, is the stress debriefing and critical incident stress, however you want to call it and everything. You do need to, people need to talk it out afterwards and everything. It all works on us after a while in there. And again, especially if you're dealing with people that you know, or the little ones has a tendency to, again, as Joel said, from the heart a little bit more than the mind. in there, and it can be very debilitating in there. So again, make use of your resources that you have. Know where your local crisis intervention or debriefing organizations are within your jurisdiction, everything, and make use of them. And peer-to-peer counseling is a great is an underutilized resource out there.
Jared's made some comments. Joel, did you want to?
Yeah, I really appreciate that. Specifically, that pediatric trauma should be considered abuse until proven otherwise. I think that's a pretty good rule out. Preserving the scene and making sure that we document accurately what happened. And our classic training of looking for things like varying bruises and conflicting stories is a good start. But anytime we see someone who's young and has trauma that's not consistent with the mechanism, we definitely want to worry about that. And Jackie brings up that there's free PEP classes when we reach out to the EMSC folks. So yes, we have funded education programs. And Hallie, I think you're right. A lot of the things would be very similar for people who are under 18. I think the standing order for over 18 or 18 years and older is great. And then I think if it's a kid and we really don't want to resuscitate at all, making that confirmation call to medical direction is a great idea. And if you feel better working it, by all means, there's nothing wrong with choosing to work an arrest and let the doctor at the hospital make the decision.
Yeah, seriously, if you're uncomfortable at the scene and you're up against it, dial it up.
Do it.
Take it up to the next level. At McSwain Trauma Education Project, this is one of the things that we do. We also do the conferences. All these things are based on input from you. The places where we do our conferences, we got those conference sites from you guys. You know, you told us you had a place, you had people that are interested. We can bring the team to your site. If you have topics that you'd like to see us do, the topics come from you guys. Again, we're not making any assumptions that we have access to science, we have access to the literature, we have access to the work that we do, but we don't want to make any assumptions that we know what you need all the time. So tell us what you need, what you want to hear about. It's never wrong to say that all you want to do is be talked to about something or discuss something that you're uncomfortable with. That's important. We addressed that tonight, and then I think we're going to be talking about it again further down the range. And again, to Mary's point, I want to thank Joel for treating this topic what it is, what it actually is, which is simply somebody who is not survivable of this particular event. And that's what we're going to talk about, that happens. There's a judgment that needs to be made. In many cases, it's because resources are important to protect. You know, if you've only got X amount of ambulances, you know, from the urban places where it could take you an hour to get an ambulance, even though you live in an urban setting where there's lots of them, they're all busy. Or if you go to a rural setting where when the ambulance leaves town to get to a hospital 2 hours away, who's going to take care of the next call? You know, we have to consider the expenditure of resources when it's not going to help the situation. And are we making the best call for everybody? Tough stuff. And I think Joel did a great job of steering us to that conversation. So again, take a look at the website, seeing what we're up to, what we've got planned, what's coming up. If you have an idea for a place that you'd like to see the McSwain Trauma Education Project Conference come to, let us know. If you have topics that you'd like us to talk about, give us those topic ideas. Even if you have speakers that you'd like us to know about it. You heard somebody that was great, you know, talking, or you really love your medical director and you'd like to let us have at him. Well, you know, whatever you've got that we might be able to use, we'd be happy to hear about that.
Thank you. It's a pleasure to carry on Dr. McSwain's goal to keep up with training for everybody around the country.